as Institute of Fitness Professionals, or FitPro for short, we are really proud to be associated with Exercise Medicine South Africa, and we're playing a vital role, I suppose, in educating. Not I suppose, we are playing a vital role in educating the public and fitness professionals in their roles as members of the Exercise Medicine Solution and Exercise Medicine team. The objective, as I said, is multi-focus this evening. There are multiple levels here, one being at a professional level, and hopefully will resonate with those trainers, our colleagues amongst the audience, and those that are currently involved with training people and helping them improve their everyday lives. Also, there might be one or two guys from the healthcare professional side. This might be, we're trying to keep a little bit low key in terms of scientific data and everything, like scientific jargon, just so that it is appealing to the general public, but also so that they can gain something from this whole interaction and this hour of their time. Before we start, I'd just like to introduce Exercise Medicine itself. It is a global initiative. The vision of Exercise Medicine, the global initiative, is managed by the American College of Sports Medicine. Their goal is to make physical activity assessment and promotion standard in clinical care, connecting healthcare with evidence-based physical activity resources for people everywhere and of all abilities. EIM encourages physicians and other healthcare providers to include physical activity when designing treatment plans, and to refer patients to evidence-based exercise programs and qualified exercise professionals. In addition to that, EIM is committed to the belief that physical activity promotes optimal health and is an integral part in the prevention and treatment of many medical conditions. So that is a statement available on the exercisemedicine.org website, and this is where we take our initiative or our guidance from. So the next slide, this picture might, well, I've put in a presentation before and someone said, Flip, you're taking a big chance here. You know, you've taken, it looks like you're taking on the pharmaceutical industry. So the pharmaceutical industry does not create cures, they create customers. Now, that can be perceived, that is completely open to perception. So, as I said, people believe, oh, jeepers, he's taken on the pharmaceutical companies, and I definitely am not doing that, because this can be from the other side of things. As a consumer, we see medication is the only way out. So if we suffer from a chronic illness, we're more inclined to quickly try to take a pill to help us deal with that condition. So we become lifelong customers of the pharmaceuticals, not realizing that, yes, you know, in any situation, we never say no to medication. If it is prescribed, it's one thing straight out, and we really reinforce that from a fitness professional side of things. We never say medication doesn't have a part. What we want to try and get across to everybody out there, and to those that are suffering from non-communicable diseases, and to trainers who are involved with people with non-communicable diseases, is that exercise and medication and lifestyle, behavioral changes, all those kind of things play a vital role in the total solution to help someone manage their non-communicable disease. So what this picture is about is more like there are perceptions out there that medication is the be all and end all, and no, it's not. And even pharmaceutical companies are aware they're a part of a solution as opposed to the only and ultimate solution. So just to go into some definitions here, bearing in mind, as I said, we have quite a mixed audience this evening. And you generally, if you mention the word fitness to people, usually what comes to mind is someone in running kits, perhaps running a marathon and stuff like that. Whereas, and which for a lot of people that perhaps are inactive or sedentary or not really involved in fitness or training themselves, it can be quite intimidating. So we need to change that a little bit. And the only way to do that is to really define what we mean. So there are two different types of fitness that we're going to deal with. The first one being health-related physical fitness. And it says that portion of physical fitness directed towards the prevention of and the rehabilitation from disease, as well as the development of a high level of functional capacity for the tasks of daily living. Now, the tasks of daily living for some people are just rolling out of bed comfortably, or making up a flight of stairs without having an asthma attack, or puffing and puffing. And you know, so everybody's different. Just moving around for some people can be very challenging. On the other side, we have physical fitness as a definition here, given by Denise Plowman. It says a physiological state of well-being that provides the foundation for the tasks of daily living, a degree of protection against hyperkinetic disease, and a basis for participation in sport. Now, obviously, the physiological state of well-being, that goes to internal metabolics and all of the physiological functions in our system. The tasks of daily living here, as mentioned above, but perhaps a little bit taking it up a notch, not just for this as a human being, but maybe based around our occupations and so on. So, for instance, the person's task or function in the day may be related to their job. So maybe it's a sports person, their level is obviously much, their requirements are much different to somebody that perhaps is just works behind a desk all day and needs to keep their posture upright, breath, be able to move properly, not have poor mechanics and so on. Then the next bit could have easily have slipped into the health-related physical fitness one as well. It says it provides a degree of protection against hyperkinetic disease, and that hyperkinetic phrase means diseases associated with lack of activity, which goes towards where we're leading to this evening about the dangers of a sedentary lifestyle. And the last one is a basis for participation in sport, and that's not your Saturday afternoon post-bright touch rugby session. That is a sport in which you're taking part regularly. So not sort of like hold my beer, I'm going to play touch rugby and inevitably wind up in the physio or the chiropractor on Monday morning to try and get yourself straightened out. Most people are unable to differentiate between the two definitions, but in essence we should, because the perception once again can be something that holds us back. And it is our objective as educators, as trainers and so on, to get that across to people, to the general public, that fitness isn't about whether you can run a marathon. It's not about whether you can lift the heaviest weight, to do whatever. It's not about that. It's about being the most functional human being you possibly can and be healthy and be able to benefit from your health, especially in terms of managing or prevention of non-communicable diseases. And so health is a fundamental requirement, and often our exercise prescription plays a major role in the management of any areas of ill health. And for this reason, exercise needs to be prescribed correctly. And scientifically, as you looked in, as I mentioned in the introduction about the the exercise medicine front page on the .org page, it's mentioned scientifically based prescription, and that's vital. We always use science. Science is there. Loads and loads of money gets spent on research, on exercise, the benefits thereof, the relationship with different with exercise and different non-communicable diseases and so on. So the science is there, and that must be applied correctly, because once we apply it correctly, our likelihood of success is much greater. But the key word here is prescribed. So for those fitness professionals out there, our prescription, we talk about throwing up someone's program. Ideally, we should be saying we're prescribing activity, because prescription means in the right doses, we achieve a particular objective, and that's how we relate it to the medical side of things. So welcome to Exercise Medicine South Africa, and hope you take what you can from this presentation. Please don't forget to interact on either our Facebook page or on the live feed, or on the message option on the Zoom panel itself. Exercise and health. Now, physical inactivity has an astonishing array of harmful ill effects, health effects. What's rather important, and I wouldn't say a bit of a buzzword because it has been around for a while, although many people are not quite sure of the definition itself, a sedentary lifestyle. So sedentary relating to a complete lack of activity. And one, according to current definitions, a person is sedentary having not undertaken physical activity for more than 3 months. Now, for many guys, they come to do some training, and the last time they really did activity was in matric, and they played first team rugby, for instance, and they're now 25 and they still think that fits. But they haven't done a stitch of exercise since then, but they were fit and strong and they're still young, not realizing, of course, though, that not being active for those couple of years, besides having an effect on their performance fitness levels, their actual physical fitness levels, it's had a major effect on their health fitness levels as well. And that classification of 3 months it needs to be taken to heart. 3 months is not actually a long time. So we are sedentary for 3 months or longer, or we are inactive for 3 months or longer. The effects on our body can be really, really dangerous. Okay, and the benefits of the training that we had achieved till then can be undone, unfortunately. Exercise is both a powerful tool for the treatment and prevention of chronic diseases and obesity, as well as premature early death. We know that there's a direct relationship between physical activity and health status. The more one is physically active, the better one's health status. The association between disease and an inactive and unfit way of life persists in every subgroup of the population. Physical activity is the major public health problem of our time. Now, for some people sitting out there, they're thinking, flip, haven't you been watching the news? There's a thing called COVID-19 going around. Is that not our major public health problem? Yes, it is, maybe. But as we go further along and we have a look at, and we'll talk about comorbidities and stuff just now, you'll see that the underlying problem is inactivity to a huge extent, and a lot more than COVID-19. If we just take a step up there, we were lucky enough to have the presentation by Dr. Robert Salas from the Exercise Medicine in the States, and he works for Kaiser Permanente, and hence the reason why the slide is one of their slides. Bob Salas is an incredible presenter, and how we got across the need for this exercise medicine approach is quite incredible. And I will be taking you through the very similar process that we were exposed to, and that sold us on the whole idea, and actually even though we've been in the health and fitness industry for a long time, it changed the whole perception of how we're going to do things. What's quite important on that point on the slide that says the association between disease and an inactive or unfit way of life persists in every subgroup of the population. Now, even though this is done based on American stats and so on, what I'm going to take you through just now is relevant to South Africa. So this affects every subgroup of our population too. The Lancet, in view of the prevalence, global reach, and health effects of physical inactivity, the issue should be appropriately described as pandemic. Pandemic is a word being thrown around a lot at the moment, so one should understand then the seriousness of the situation, with far-reaching health, economic, environmental, and social consequences. Please keep that in mind as we proceed. So what factors affect our health and longevity? Obviously, genetics plays a massive role. Just to go into it briefly, we know that for a lot of non-communicable diseases, we may have a genetic predisposition based on our family history and so on. However, we've got to remember then that just because we have a predisposition isn't a guarantee that we're going to get that particular condition. Okay? If we do not alter our behavior and our environment as much as we can, we will increase the likelihood of us getting whatever our genetics predisposes us to. Then behavior. What kind of behaviors do we have? Are we active? Do we eat properly? Do we follow a healthy lifestyle, an active lifestyle? Are we stressed? Those kind of things. Do we drink? Do we smoke? What sort of environment are we in? Are we under a huge amount of stress? Are we, what element of society are we in? What sort of social issues are we dealing with? And we have access to running water, flushing toilets, all of those kind of things. Those are sort of environmental factors that, an example of a few environmental factors that can have a huge impact on health and longevity. In the 1900s, the leading cause of death in the States was pneumonia and influenza, tuberculosis, and infectious diarrhea. All three of these were mainly related to environmental factors. Over the last century, between 1900 and 1999, there were some major achievements in public health, particularly in the USA. Firstly, there was vaccination, control of infections, safer and healthier food, healthier moms and babies, safer workplaces, obviously health and safety being a major thing, motor vehicle safety, the arrival of the safety belt, airbags, etc., etc. There was a decline in deaths from coronary artery disease and stroke. Family planning was brought about, so utilization of birth control, etc., etc. Fluoridation of drinking water, so healthier drinking water. And then recognition, this was obviously towards the latter part of the century, recognition of tobacco as a health hazard. In fact, the lifespan in the US increased. In the 1900, it went from 47 years to 78 years by the year 2000. There are two prominent American presidents on the screen at the moment, one being Teddy Roosevelt, who was the 26th president, and he died in 1919 at the age of 60. Then Ronald Reagan, who was the 40th president, he died in 2004 at the age of 93. So one could see then, that's even despite being shot in an assassination attempt, but tough character, but needless to say, a very fine example of changes in lifespan. When it comes to South Africa, our current lifespan is around about 64.12 years. In 1950, it was 43.28 years. So we've also come quite a long way. Obviously, the developments that have happened, some of which had happened here, if we take heart surgery and all those kind of things into account, South Africa made some significant strides in helping promote longevity through medicine and so on. But then we have a look at leading causes of death. So that was longevity, long life, increased life expectancy or lifespan. But there's some major causes of death globally. Now, in 2016, these are the stats from the World Health Organization. These are the death toll in millions. And our color code there, our red represents communicable, maternal, neonatal, and nutritional conditions. Communicable diseases are those that are passed on, that are infectious, that are passed from one person to the next by various means, be it blood, through contact, etc. The blue block, or the blue coding, is non-communicable diseases. And the last one being green are injuries. So if we have a look, the first three highest cause of death in millions, first is ischemic heart disease. For those who are not familiar with that, that is disease of the heart as a result of decreased oxygen supply to the heart. Also stroke, chronic obstructive pulmonary disease. And then it goes to lower respiratory infection, which is communicable. Then we go to Alzheimer's disease and other dementia, trachea, bronchus, and lung cancers, diabetes mellitus. So those are all non-communicable diseases that have had a significant role or had a significant contribution to our total death toll. If we break it down now into socioeconomic status, if you look at the lower income countries, in 2016, we'll see that the highest causes of death were as a result of communicable diseases. So lower respiratory infections, diarrheal diseases, then came ischemic heart disease, then HIV and AIDS, stroke, then through malaria. It's all the way through down to road injury, which was the only one in green. Obviously, in lower income countries, we know that there is possibly poor access to fresh drinking water, poor sewage conditions or sewers and that kind of thing. Lack of nutritious food, lack of medicine. So that will probably explain why there's such a high level or a large contribution from communicable diseases. Then we move on to lower middle income groups, middle income countries. So we can start to see here that our non-communicable diseases are taking the lead again. So ischemic heart disease, stroke have moved up, and the number of deaths caused by communicable diseases has dropped off quite significantly in terms of the total contribution. Moving to upper middle income groups, or middle income countries, should I say, you can see straight away that communicable deaths levels has dropped quite, or contribution to the total has dropped quite significantly. But what has become quite noticeable here is that a large majority of deaths are a result of non-communicable diseases. And that is a very important, as we go further into it, into our higher economic countries, once again, right the way through, much higher contribution, or in fact, almost total contribution as a result of non-communicable diseases, especially if we're looking at in death rate per 100,000 population. Ischemic heart disease, very, very high level, very high contribution, should we say. Stroke, Alzheimer's, and other dementias, the cancers around the lungs, the trachea and bronchus, your chronic obstructive pulmonary disease, all of those are major contributors, very few from the communicable diseases. Now, what I didn't mention earlier on, obviously, as we go into change in socioeconomic status of these countries, there would obviously be better access to medicine, as we know, also education. So education, as we go through education about what's good and what's bad, whether or not people heed that education, I don't know, because the numbers are still very high. And that is why it's vital for us as fitness professionals and exercise professionals to get public to understand about how to change their lifestyle, bring about the behavioral changes that will be necessary to drop these levels. Yes, we're not all going to live to be 100 or 90. You die because something's wrong and something stops working, yes. But in addition to improving longevity, we're also looking at improving quality of life. And one of the best ways to do that is utilizing exercise. If we're able to move around and we managed to hold quite a few of these things at bay, a lot of these conditions at bay through activity, our quality of life will be so much better. In South Africa, the total number of deaths in 2015 was 460,236. The highest number of deaths that occurred in 2015 were amongst those aged 60 to 64. years, while the lowest number was observed amongst those aged 5 to 9 and 10 to 14 years. Overall, there were more male deaths than female deaths in 2015, from infancy up until the age of 65 to 69, after which there were more female than male deaths. Over 55.5% of those deaths were attributed to the group of non-communicable diseases. Communicable diseases accounted for 33.4% of the deaths, while injuries were only responsible for 11.1%. Still a lot. And the trend has been the same since 2009, where more deaths were due to non-communicable diseases than the other two groups. Now remember, what's quite important here, especially for those that are just joining us as members of the public, a non-communicable disease is a disease that cannot be passed from one person to the next. And we know that they have been in the headlines quite a lot lately, especially since the COVID-19 pandemic started. Now, a non-communicable disease, also referred to in these cases comorbidities. You would have heard of comorbidities a lot more than a non-NCD or non-communicable disease in the normal press and unfortunately on social media and so on. But those comorbidities include these non-communicable diseases. And once again, these are the people that are at greatest risk of contracting COVID-19, or at least having a very bad reaction, or let's be hospitalized for it. So our non-communicable diseases that we cover under our exercise and medicine program are diabetes mellitus, coronary artery disease, hypertension, chronic obstructive pulmonary disorder disease, asthma, cancer, and depression. The people with comorbidities, like we said, are at highest risk of death if they're infected from COVID-19. And if there was ever a time to bring about change, as I mentioned at the beginning, this would be the time. Unfortunately, unless it's activity or the use of exercise as part of our total solution for a person's or the management of the non-communicable disease, most people have been relying on medication. They don't take their conditions seriously enough. Okay, fine, I've got diabetes, I must just take my insulin and manage my diet, and that's about it. Then all of a sudden, along comes COVID-19, and suddenly your threat of dying earlier is much greater. And I think for a lot of people, this was a shock. In fact, to be honest, I hope it was a shock, because the solution is not that hard. If we get people active, the chances of the likelihood of us managing the condition properly as part of the system, as part of the total solution, is so much greater. Their resistance to these infections, these things like COVID-19 going on, are much greater. And that's ultimately what we're looking for, better quality of life overall. What was quite scary, and this was one of the slides I showed, I mean, we've worried about obesity quite significantly, but this inactivity or sedentary lifestyle has passed obesity as being a major issue. And I think this slide for me struck home a lot. I have children, and the statement that this will be the first generation on pace not to outlive their parents. And any parents, I'm sure those parents out there would agree, your biggest fear is outliving your kids. And now it is becoming a reality, and not through traumatic things, but more about through behaviors and lifestyles that we can change. Sedentary death syndrome, are we on our way to extinction? So the inactivity epidemic is more concerning than the obesity epidemic, as I mentioned just now. And I like to call this diagram the devolution of man. Obviously, we're not going to be contesting evolution. Some people have different beliefs and so on. But if we were the chap in the middle, that nice upright posture, caveman capable of hunting and gathering and looking after his family, right down to the chap hunched over his computer with a really poor posture, I'd like to think that the chap on the end is still only at the top of the food chain because we have gunpowder. But as a functional human being, not great. And as a lifestyle that we should be trying to protect ourselves against, that would be the perfect example. Hippocrates, although bearing in mind obesity is not the problem, eating alone will not keep a man well. He must also take exercise. Food and exercise work together to produce health. So even as far back as Hippocrates' time, people realized, or there was the understanding, that one must be active, that human beings are designed to be active. We have highly adaptive bodies. If we prescribe and put them under the right amount of stress, we can bring about a huge amount of change, just even on a healthy individual. but even more so in those that are sedentary and have predisposition to or have a non-communicable disease. Here is an interesting research study done on 31,000 London transport workers. Now, there might be some younger people that have joined us on the Zoom. I'm not too sure, so please forgive me if I sound condescending. I kind of forget where we fit in the whole timescale thing. Yeah, I keep thinking that I'm young, but I'm not. So a study was done on people involved, or the guys involved with the London transport, and we have drivers and we have conductors. And of those two groups, there was when they had a look, when they did a research on the prevalence of coronary artery disease, they found that from a coronary occlusion perspective, the drivers superseded the conductors by miles. And when we shifted across, you look across to the second section of the bar graph, it says there, early mortality within 3 days of a myocardial infarction. So after myocardial infarction, the likelihood of the drivers passing away was much greater than the conductors. What was the difference? They both worked the same shifts. In fact, they obviously team up quite a lot. But the conductors walk up and down the transport, collecting people's tickets or stamping their tickets. These days, obviously, there's probably automated system, or there are automated systems. But back when this was done with a human being, that conductor would walk up and down the entire day. And as a result of that, there were dramatic changes in his heart, or his or her heart, that helped them will minimize the likelihood of coronary artery disease and the severity thereof. Physical activity lowers mortality, yes, even with our increasing age and chronic disease. That's a very fit granny over there, and I hope we can all be like that someday too. In terms of death rates and fitness levels, we know that the fitter one is, the likelihood or the death rate will be much lower. So if we look at the classification here, low fitness level, moderate and high, low being red, moderate in yellow, and high in green, we know that across the age groups, there's a significant difference in those that participated in physical activity versus those that did not. Once again, it is just a graph to highlight a fact we've already pointed out. And then just a quick, before we go into the next few slides, I just want to make sure you understand the units that we're going to be dealing with, the units of measurement called the metabolic equivalent. One MET is the rate of energy expenditure while we're sitting at rest. So while we're in a complete state of rest, lying down on a bed, the rate of energy expenditure is called a MET. Now, the rate of energy expended during activity is the ratio of the rate of energy expended at rest. So the number of, if you look at the example here, if a person does a 4 MET activity for 30 minutes, he or she has done 4 times 30, which is 120 MET minutes, or 2 MET hours of physical activity. Now, South Africans, we generally do not deal with METs, and we look at calories, and those are kind of our indicators of energy expenditure during training. But a lot of our guidelines from America are that do utilize the metabolic equivalent. If we look at this bar graph here of different activities, there are from volleyball, golf, dancing, backpacking, basketball, and soccer or football. We look at the metabolic equivalent, the numbers at the end of the colored block. And that tells us what the energy expenditure is like while engaging in that activity. Obviously, football down at the bottom, we also look at the caloric expenditure, 300 to 375 calories, yes, but it's also 10 METs. Why this is important is when we're looking at chronic disease mortality, there's once again a direct relationship between our activity levels and the mortality rate. So someone with a low level activity, less than 5 METs, has a higher risk of death from hypertension or high blood pressure, from coronary obstructive pulmonary disease, then diabetes, much higher again, smoking, and BMI. What's quite interesting there, smoking element. So someone that smokes but is active, actually, if you look at the relative risk of death, it's pretty similar to someone that has diabetes or hypertension and so on, but we kind of think of smoking as being the absolute worst. Yes, it is, and I'm not promoting it or saying that it's fine, but if we're looking at the complete all the risk factors. So ultimately, if someone is a smoker and they're maintaining some level of physical activity, preferably towards 8 METs or greater than 8 METs, they are reducing their overall risk. We have Lee, my wife, often has a saying, we watch guys going to smoking areas on the office campus that we are situated on. And the guys go to a smoking area and they stand still and smoke. But perhaps if they smoked while they're walking around the entire office park, which is about 1.2 Ks if you look at the inner ring or inner ring road, they might be able to, to have their smoke break, but at the same time be active. Possibly a good thing. So exercise, as we know, though, is a very cost-effective medicine. Now, I'm going to show you a couple of examples. They do use American examples again, but what I just want to get across here is if we look at met hours per week again, so someone participating in exercise, we know that there was, from the studies that they did on 61,200 postmenopausal women, that there was a reduced risk by 55% for those that were physically active of 24 met hours per week, which is quite significant. But if we look at the cost of drugs to treat osteoporosis, and that was why they're related to hip fracture, the drugs per year, cost per year, are phenomenal. And if you look at something at the bottom, especially under where it says Forteo, which is one of the drugs used to treat osteoporosis, it says the efficacy longer than 2 years is not established, may cause osteosarcoma in rats. And what they say that it's not, the efficacy is not yet established for greater than 2 years. So, look, you don't really know. You might be spending all this amount of money, but stuff's not guaranteed. Nothing in life is guaranteed, but the more variables we can control, obviously, the better we are. Exercise and dementia. So, we're looking for mental wellness, mental health. People that engage in physical activity more than 3 times a week. And this was on a study done with 1,740 men and women older than 65 years. And they'd been part of a 6-year study. There's a drop off in 40% of their risk, or the risk of dementia was reduced by 40%. Then we look at the cost of Alzheimer's drug treatments, and the scary part at the top there says no evidence that these drugs prevent dementia, may delay progression by 18 months. So, we can't prevent it, in other words. However, should we adopt a healthier lifestyle, we reduce the risk of developing dementia quite significantly. And that is what these slides are trying to get across. Exercise is a treatment for depression as well. We know one of the fastest growing non-communicable diseases globally is depression. And I think that number during lockdown must have grown absolutely, gone ballistic. And I'm sure anyone that got tied up at home, look, if you got your family and a support system around, outstanding, those that were on their own, and even kids that are not going to school and, break a routine for this period that we've had, particularly in South Africa with an extremely long lockdown period, I think depression increased quite dramatically. Now, if we look at, they did a study with just with brisk walking, so not running, nothing hectic. I don't think they didn't include resistance training or anything like that. It was a 40% better chance in remission for people that engaged with 180 minutes a week of exercise, which isn't a lot. 150 minutes a week is very achievable, and once again, it's a brisk walk. It's nothing too strenuous. But we all know that, or we should know by now, that you do feel good after exercise. That's what our ultimate goal is. The objective of any training session is to walk out of there feeling good. And if repetitive training makes that a chronic condition, in other words, feeling good and happy, well, then it's doing its job. If we look at the cost of drug treatments for depression, once again, significant costs. And what's even more scary, so I just used the example of Zyprexa at the bottom. Important information. So the worst thing you can ever do is open an insert on any of these chronic medications, because if that doesn't give you a heart attack, then I don't know. But if you have a look at some of the content here, this is pulled off some the drugs.com website. Zyprexa may cause heart failure, sudden death, or pneumonia in older adults. Okay, if that's not going to cause you to feel even more depressed, I don't know. You may gain weight or have high cholesterol and triglycerides while taking this medicine, especially if you're a teenager. Your blood may need to be tested often. You need to visit your doctor regularly. It can also cause high blood sugar or hyperglycemia. If you're diabetic, check your blood sugar levels on a regular basis while you're taking Zyprexa. So, once again, yes, there's definitely a place. Please don't misinterpret this. There is a place for medication for sure. However, it is only one cog in the wheel, or only one part of the actual solution. And if we look at exercise and the right dose, there are very, very few side effects. Once again, of course, and very few side effects, but we also have unlimited refills. Yeah, I really enjoy this little graphic. It says there, what fits your busy schedule better? Exercising 1 hour a day or being engaged 24 hours a day? It's quite classic. I mean, even as a trainer, I think, oh, flip, and I run out of time, or we don't put enough time aside because we're looking after clients or sports teams or whatever we may be doing, and we tend to even neglect ourselves, even though we know better. Oh, well, I'll just skip today, I'll do tomorrow, or I don't have enough time. At the end of the day, as we go through and we look at how to actually dose and prescribe activity, it doesn't actually require that much time in the day. And hence, once again, it's about a prescription. And if you have a look at this infographic as well, so the tremendous health benefits are seen even with low levels of exercise. This is from the University of the Free State. The amount of exercise needed to benefit health is much lower than the need for fitness. So once again, re-emphasizing what I spoke about just now. Regular physical activity at the correct intensity reduces the risk of heart disease by 40%, the risk of stroke by 27%, reduces the incidence of diabetes by almost 50%, that's obviously type 2, and reduces the incidence of high blood pressure by almost 50%, can reduce mortality and the risk of recurrent breast cancer by almost 50%, reduce the risk of colon cancer by over 60%, can reduce the risk of developing Alzheimer's disease by 1/3, and can decrease depression as effectively as Prozac or behavioral therapy. Once again, not as a replacement, may become a replacement in the future, depending on how the person's individual situation, but once again, part of a total solution. So why, understanding all of this, why has the medical fraternity sort of neglected physical activity as a treatment? I can honestly say I've never been at a doctor's rooms and they said, maybe because they kind of know what discipline or what work we do, but they never really look at your physical activity unless the only thing they've ever said is, right, okay, you're sick, don't exercise. Okay, you've got flu, don't exercise. Okay, that's fine. There are very few doctors out there, and obviously I stand under correction. If there are any doctors listening, I hope that I'm not offending you or that you don't fit into this category, but very often doctors don't prescribe activity. And hence the reason why the webinar last night was aimed at healthcare professionals, because we've got to attack this from both sides. One from the medical side, making it part of their normal prescription, and then from the exercise professional side, the fitness professional side, we can provide a service to the patients of those doctors by helping them execute or participate in a very scientific-based exercise program. What's quite important, if you look at the text here, it's easier for a physician to issue a prescription to reduce blood pressure, cholesterol, glucose, or BMI. But what's also quite important to understand, so it's easy to prescribe. Remember that diagram in the beginning with the pharmaceutical company and pharmaceutical company create customers, not a solution or not a cure. Similar thing here. It's much easier to prescribe a pill because people with another condition, especially perhaps if they've got a fright, my blood pressure is really high, my risk of dying young is much greater. Let me take that pill. That's going to make the difference. And they become a little bit fixated on the medical side of things, not so much on the overall solution. The problem being, though, is that adherence to that medication is very low. As soon as they start to feel better or the blood pressure comes down, people stop taking their medicine. That happens with things like depression too. People start to feel good. What do? They stop taking the antidepressants, and all of a sudden they have a major depressive episode again. Very important here, it says the reliance on pills transfers responsibility for health to doctor, resulting in low patient physical activity. So the responsibility is now the doctor's. There's no accountability. By educating people, by helping them understand that exercise can be a massive contributor to their well-being, you're almost putting the ball in their court as well. You need a little bit of accountability. If you're in a physically bad state and perhaps be diagnosed with a particular non-communicable disease, we need to own that and say, okay, Phil, what am I going to do about that, and what can I do? So we need to be accountable. We can't push the blame onto somebody else. And once again, that's a behavioral change, and why a multifaceted approach is required. Sometimes the person needs to go for counseling. Often, particularly with non-communicable diseases, they have support groups that help people understand about this, because often it can be a big shock. But those support groups also help people to understand that they need to change certain habits or behaviors, and hopefully motivate them to take responsibility for themselves in the management of their NCD. There's a widespread belief that we cannot change physical activity habits. However, evidence-brief counseling and pedometer programs can increase physical activity. We're able to convince patients to take insulin shots, chemotherapy, etc., but why not exercise? There are tons of tools out there, and you will see various medical aid companies offer point system for your physical activity and reward systems, and you've got apps on your phone that read your number of footsteps, that monitor your activity. Guys are trained with heart rate monitors. There are all of these tools out there that we can also utilize to help motivate us or give us goals to train towards, and that we as trainers can help our clients say, right, you need to achieve this level of activity, or you need to train at this heart rate for this particular duration or period of time in order to get maximum benefits. Right. Now, obviously, I'm going to ask this rhetorically because the feedback I'm not going to be able to see on either of the platforms, unfortunately. But this, and I couldn't resist putting the slide in because it confuses quite a few people. It's not an old vape, pretty close for those people that might be thinking that. But what it's called is a tobacco smoke enema. Hence the term blowing smoke up your ass is actually a medical term. So this was used to treat a whole variety of disorders, from constipation to depression to all kinds of things, but basically that's where this term came from. And on the topic of smoking, the health burden of inactivity versus smoking. This is quite something to think about, because I know it's probably quite interesting at the time because tobacco is back in the news, with it being withheld during lockdown. I suppose we're not supposed to offer opinions here, although I do think that was an exercise in futility. Anyway, just to give, a lot of people associate smoking with bad health, which is great because it's a good association to have. But have a look at the comparison here. 1 day of being active has roughly an equivalent health burden to smoking 3 cigarettes. So the damage to your arteries through smoking 3 cigarettes is quite significant. So 1 day of inactivity is equivalent to smoking 3 cigarettes. So being inactive for a whole week is the equivalent health burden to smoking a pack of cigarettes. Okay. Now, interestingly enough, what's the first thing a doctor will tell you to do is to stop smoking. And often when if we're training trainers or qualifying trainers, and we say to them, give them a hypothetical situation. Someone comes to them, they smoke, they drink, they eat badly, and they don't exercise, and they want to turn over a new leaf and become a completely new human being and bring about a whole new group of behaviors. One of the things we say, right, start introducing exercise first and then slowly worry about everything else. Because as soon as we try to change too much, I'd rather the person was active and we worry about them quitting smoking later on. Don't say to them, right, okay, you need to stop smoking, you need to stop drinking, and bond with exercise. It's too much in terms of the behavioral change. You're never going to bring about long-term change there. But once again, this is an example of something that's really bad. For body inactivity is worse than smoking. So what can be done? What are we going to do about it? So from a healthcare provider or health professional's perspective, once they understand the importance of exercise, it should be part of their exercise prescription. Okay, and it gives you a quick guideline here. Physical activity should be recorded as a vital sign. Patients should be advised to do 30 minutes of moderate exercise 5 days a week. We're going to talk about the actual prescription stuff a little bit in a few moments. But doctors and healthcare professionals should be giving this out. And once again, there was a lot of talk last night because of, as I said, on the webinar for the healthcare professionals, there were a lot of different disciplines in attendance. So physiotherapists, biokineticists, doctors, and everyone has a particular, they were brought up their scopes of practice, etc. So basically responsibility, legal and ethical responsibility within their qualification. And obviously tonight we're looking at the fitness professional side of things and the general public to hopefully inform you. But what's really important here, despite the fact there are scopes of practice, I'm kind of forgetting that we all should be geared towards helping our patients, our clients. So whatever way we can, whether it's by referring up the chain to a doctor to say, look, this is what I've picked up in this client as a fitness professional, and I screen that person, and I pick up something I'm not happy with, refer up the chain or up the ladder, or the ladder of responsibility there, and vice versa. Doctors believe that this person needs to start participating in exercise, refer them down. They need to go to a biokineticist first, or the doctor's quite comfortable that they can be handled by a trainer that is exercise medicine accredited. Perfect. The clashes, the scopes of practice stuff is a debate that will forever be ongoing, and we will never solve it straight off like this. But what I do believe, though, and what we're trying to achieve as FitPro, as partners with exercise medicine, we need to create a network or an understanding between all of our disciplines that at the end of the day, yes, we are our own business, we have our own responsibilities and so on, but we're supposed to be making society better and making people healthier. That is what we're there for. So in terms of our prescription and our doses, so many of us will know this, but let's go through it as a matter of course. And for those that are not familiar with this, feel free to take some notes and so on. So now, exercise is a number of different components, those of which we're going to go through them. We'll go through the major ones through this presentation. We're going to start with aerobic training. So activities, your long-term, your endurance type activities, and by definition, aerobic activity is a continuous movement, a rhythmical movement that uses large muscle groups. So that may be swimming, it may be cycling, it may be walking. Either of those, continuous for extended duration of time, where the body is pretty comfortable. And we're looking at, when I say comfortable, we're looking at a moderate intensity. So moderate, and for the minimum duration of 150 minutes a week. Now, let's just, before everyone goes flip 150 minutes a week, that's nothing. But remember, we're looking at health and health-related fitness, not fitness for performance or participation in sporting and so on. So if we take the average person who is sedentary and say to them, right, we need to get you to be doing 150 minutes a week. And if that is 30 minutes a day, fantastic. And like we said, people go, oh, but I don't have 30 minutes a day. The beauty of this is that your body is this responsive that if we break that 30 minutes into 3 bouts of 10 minutes during the day. So as you arrive at work, go for a walk around the parking lot quickly, just for 10 minutes, go back, go into your office at lunchtime, take another 10 minutes. And at the end of the day, take another 10 minutes before you get in your car and you go home to go sit on the couch. You've done your quota for the day. At the same time, that stimulus, that stress on the body, once you get into a habit or once you get into routine and are doing it repetitively, will start to bring about quite phenomenal changes. And as we get more comfortable and healthier, we're able to extend the duration. So we'll extend the duration first before we bring about changes in the intensity. So the intensity from moderate to vigorous. We do know, of course, that some people that are able to participate at vigorous activity, they may drop the time required to achieve the same benefits by half. Your different intensities. So if we look at what moderate intensity is, if we look at, let's look at perceived exertion. We've seen percentages of heart rate and of VO2 and heart rate reserve and so on. Those are very scientific, but let's look at it on the rate of perceived exertion scale. Just for those that are perhaps not, haven't really heard of perceived exertion, it was created, the scale for perceived exertion was created a number of years ago, and it's usually called the Borg scale of perceived exertion, and is ranked, the perception of activity or stress exertion is on a scale of 6 to 20. Some of the scales work from 1 to 10. So by getting someone to work at a particular intensity, moderate intensity is around about 12 to 13 out of 20 in terms of stress. It's very light, comfortable person who talk comfortably, and they can maintain that intensity for quite some time. All right, that's what we're looking for, moderate. When it starts to become vigorous, or when it's classified as vigorous, we're working at perceived exertion from 14 to 17. If we take it beyond vigorous to a very, very challenging level, this is where your rate of perceived exertion is around about equal or greater or equal to 18. Perceived exertion, like I said, was created quite a while ago, but has since become a go-to again. We use it a lot for athletes as well after sessions, so part of their feedback, they give us a perceived exertion. But it's a little bit easier if we get someone to understand what their perception is of that session, so they understand that this was a relatively comfortable session, and I'd give it a scoring of this, and they can understand and associate those perceived exertion levels with a particular sensation or feeling in their body. It enables us to help with their prescription. Ultimately, it would be nice to be able to train everyone with heart rate monitors, but sometimes it's not always possible. In terms of resistance training, so if we're looking at the total approach, so these are all based on the American College of Sports Medicine protocols and the prescription for particular groups in the population. What's quite interesting, obviously, diabetes would be slightly different because of the need to administer medication and monitor your blood sugar levels, etc. So some of the protocols are slightly different. However, you will see if you're going to investigate this, and a lot of the information is available, and you see the guys that are attending courses, the exercise medicine course. The protocol is very interesting because a lot of the stuff that applies to apparently healthy adults also applies to many people with the NCDs or non-communicable diseases, so hypertension, diabetes, depression, and so on. A lot of the prescription is the same as for a healthy adult because it's part of the management process, and the perceived risk, because the risk is less, and we always look at risk here in terms of cardiovascular risk. Everything else we can kind of manage quite comfortably. Cardiovascular risk is one of the deciding factors in terms of our prescription as well. From a resistance training perspective, prescription for healthy adults taking into account any contraindications like retinopathy, that's kind of things where a person can't be loading their system too much. We're looking at a frequency of 2 to 3 times a week, an intensity of 50 to 80% of your 1 repetition max, depending on your training experience. When we're loading for resistance training, ultimately, and this is the approach we try to preach, remember, we are looking at improving that person's functioning as a human being. So that is about improving someone's posture, improving their ability to move. So the approach is to improving movement. And unfortunately, resistance, if I use the term resistance as opposed to strength training, because strength training often, just like that fitness, that perception of fitness is about someone in a running kit. When we mention strength trained people and they just tend to see barbells and Olympic lifting bars and that kind of stuff, which can freak people out. But if we take resistance training and we expand it to just understand that just getting someone to use their own body, to be comfortable utilizing their own body to improve their functioning, that is ultimately the goal. And 2 to 3 times a week is more than sufficient. If it's someone that is sedentary, obviously we're going to build them up very slowly, and naturally as part of the prescription process, it is vital for us to take someone through an assessment as well, just to help us with the accuracy of our prescription and meeting their physical requirements. If we look at the types of prescription in terms of resistance exercise, it says 5 to 10 exercises using large muscle groups, 10 to 15 reps, aim at reaching near fatigue. As our load increases, they should be able to complete 8 to 10 repetitions. This can be done for 1 to 4 sets. So it focuses on big muscle groups. Once again, our larger muscle groups help us with our conditioning. They also affect our cardiovascular system, our heart, our circulation system. They increase capillarization of working muscles, which is also great. They're one of the great side effects. And when we work in larger muscle groups, we tend to replicate or utilize the functional movement. There's just a little bit of a breakdown in the muting status. And once again, our loading, as we understand for normal strength training, will follow a path of gradual progression. Then moving on from the resistance training, once again, our progression should be gradual based on the client's adaptation. And progression must be in the form of load, sets, and then frequency. Progression for 6 months to 3 times a week of 3 sets of 8 repetitions done at 75 to 80% of 1 repetition max and 8 to 10 exercises may be an optimal goal according to the ACSM. The resistance training modalities, body weight first, I believe, elastics, dumbbells, kettlebells, machines. At the end of the day, any tools that are available to you that are firstly safe and that are going to allow you to achieve the particular objectives you set out for that client. Like I said, body weight first is great because we need to carry our own body weight around. So the more comfortable you are with body weight stuff, and it's also for a lot of people less intimidating than saying to them, okay, here's a kettlebell, here we're going to do some work with the kettlebell. Just try and find exercises that utilize body weight first. Once again, looking at different levels of intensity. So in terms of percentage of 1 repetition max, for those that are joining us just from the general public, when we are looking at prescribing strength training or strength loading, should we say, we look at the person's 1 repetition max. Now, a 1 repetition max is the maximum amount of weight that can be moved or in 1 complete repetition of an exercise. Take some of the sedentary and expose them to a 1 repetition max test would be nothing short of lunacy. But we have different tools that enable us to predict a 1 repetition max, or we just err on the side of caution and work very, very light, help them refine their techniques. Skill acquisition is very important, and at the end of it, be able to take them through their normal strength program. Flexibility training. So in terms of our flexibility, remember that one of the major things in terms of human functioning is our posture. If we have a poor posture, static and dynamic, we will not be able to move efficiently. And by taking on an active lifestyle or becoming more active, by changing from a sedentary lifestyle to an active lifestyle, one of the things we often have to correct is our posture. And once someone's posture is correct, they move more efficiently, they're more comfortable, which then enhances their experience and will improve the likelihood of a proper behavioral change. Then, just to finish off, so the most powerful step in medicine has your name written all over it. Now, as we conclude this workshop, what I'd like to just get across again is that compared to all of the interventions out there, medical interventions for non-communicable diseases, exercise again is one of the most underutilized. And it is our objective as fitness professionals, and it should be a cumulative objective across fitness and healthcare professionals, to get people to understand the need to be active and to understand, to break the perceptions down. Get away from the perception that you have to be a super athlete. You don't have to. Just get up and be active. And if that means prescribing to the person, right, you're going to take your dog for a walk. Don't forget the poop scoop, but today you're going to take the dog for a walk around the block. Fantastic. Build it into things that they will enjoy. Remember that even with adherence to medication is poor, as was indicated in one of the slides earlier. Adherence to an exercise program is also pretty hard, and that's where we have to be there to help with motivation and keep people going. But at the same time, if our dosages are correct and the person really feels good after every session, even though we're gradually loading them more and more, that feeling good should be enough to increase the likelihood of them coming back. Now, if we go too fast too soon, you often see it. The person goes to gym, and we're also guilty of it. You know, you haven't trained for a couple of years, okay, not that long, but people that haven't trained for a couple of years, they go back to gym and they hammer it and they break themselves and they don't want to go back. And so their adherence to exercise programming is pretty poor. And hence the reason why at the beginning I said we need to change our perception. As fitness professionals, we don't draw up a training program, we prescribe activity. So we think about prescription, it changes our focus. We are giving metered doses of stress to induce a particular physical adaptation. And if we think like that, the chances of us helping that client achieve their objectives and our objectives is much greater. Once again, nothing is guaranteed, and each of our clients is an individual, and we are dealing with a complex being. We know that, yes, someone has diabetes. We know how to prescribe accordingly, and working with the endocrinologists and so on to make sure that our program is going to help them achieve the best benefits. But it's something that has to be monitored, and our program always has to be dynamic. And if we can adapt it to however that person, how they present different testing and physical fitness testing and so on. So once again, all it takes is a little bit of effort on our part to help people overcome the inertia of a sedentary lifestyle and become active again, and hopefully reduce their overall burden on our health systems. And once again, last thing before I shut off, I know we've exceeded our hour here. We know that exercise across the board, light exercise, when not too stressful, can help improve our immune systems. And given COVID-19, the pandemic that's currently out there, and the fear that people have, especially those suffering from comorbidities or NCDs particularly, and the communicable diseases, activity in the right intensity and the right dose can help build up that immune system. So even someone that is a cancer sufferer, the exercise medicine protocols, the ACSM stuff covers people that are recovering from cancer, that are going for chemotherapy, that have compromised immune systems. How do we prescribe for them? Okay, because exercise, besides just making them feel good, helps with their their body's returning to normal function. If it is someone that has a communicable disease, even HIV and AIDS, with the right dose, we can help keep that immune system going. And the people suffering from HIV and AIDS are also at risk now with the pandemic. So that would be classified as one of the comorbidities, although this evening we've really focused as EIM on the non-communicable diseases. But just to keep our perspective open, our perspective a little bit broader than that. But thank you very much, everybody. I hope you gained something from our interaction. Please feel free to contact us either on the Facebook page or you can email us at info@fitpro.co.za. Should you require any information, if we can help you out with anything, if we can't assist you with something, we will forward on to our exercise medicine team. For the fitness professionals out there, we are putting together the new exercise medicine accreditation for fitness professionals, and we will be able to forward you all of that data and as to how you can go about it. And I know a lot of people are sitting there thinking, flip, and it's designed in a modular format, so it's much more affordable. But trust me, the beauty of this system is, like I said, the science is there. The research has been done. We don't really have to, we just have to be there. We have to be able to just prescribe it in the right context, and we will help that person significantly. So it's not hard work. It actually makes our lives a lot easier. We can use the science and still be human in our approach and help to get that person to have a better quality of life and reduce the likelihood of premature death. But thanks everyone for joining us, and the FitPro team and EIM team hope that we'll see you guys soon, and look after yourselves. I'm glad the gyms are open. I hope everyone's training hard and training up a storm. And those trainers out there, I hope your businesses have survived, and we look forward to seeing you in our classrooms soon. All the best, everyone.